Hello everyone, good evening. Hope you guys are doing well. Continuing with our cancer series, today we will finish cancers in hepatobiliary. Today we will focus mainly on pancreatic cancers. Pancreatic cancer is a very vast topic, so whatever are the important cancers, we'll try to cover them today. I can see all of you guys on the chat box, so if you guys can see me and hear me clearly, please give a thumbs up in the chat box so I know you guys are with me. Great. Okay, so while you people are joining in, let me tell you a little bit about today's class, a little bit about myself. I am Dr. Amrit Nasta. I am a bariatric and laparoscopic surgeon from Mumbai, and I am going to be your surgery educator on the Unacademy platform. There are a lot of educators like me on the platform covering different subjects. If you wish to learn more from us, please download the Unacademy learning app. You can follow our profiles. There are a lot of educators for different subjects where you can learn from all of us, which will help you in your NEET PG preparation. Those targeting the NEET PG in April, a recently started intensive revision batch just started couple of days back will help you prepare comfortably for your NEET PG exam in April. Those who are targeting later exams can subscribe for different durations depending on what your target is. Please use my referral code 10surgery and that will get you a 10% discount on the Unacademy subscription. Also, don't forget to participate in the Unacademy Combat. Combat is a quiz, it's a free quiz, you just have to register, there is no payment, and if you win, if you come in the top 3, then you get amazing vouchers as well as for the top 100 rankers. So do come for that. It's on coming Sunday, it's at 5 in the afternoon. Just use this code to register. There are no fees for this, it's a free quiz. Of course, there are a lot of subscription models for the Plus platform and for the Iconic platform where you get double benefits of Plus as well as Prep Ladder. So whatever exam you are targeting, please take the subscription accordingly and use my referral code 10surgery. And that code will get you a 10% discount on whatever plan you take. Now coming to today's class. Pancreatic cancers as such is a very vast topic. It's really speaking more of a postgraduate level topic, but for NEET PG they will always ask a few questions, especially on endocrine tumors. We will try to cover both endocrine tumors, exocrine tumors all together, but this is a very crucial topic. One or two questions will always come from this, and it's a little difficult. You read the books, you solve MCQ, still there will be some confusion. My goal today is to just make your life easy on these topics, so that whatever they will ask you, a standard question you should be able to answer. इसमें mistake नहीं होगी. Definitely after today, that clarity of thought will be there. Should I do MRCP? What is obstructive jaundice? What is endocrine? What is exocrine? What is IPMN? ये सारी चीजें थोड़ी clear हो जाएगी. Should I do Whipples? Should I not do Whipples? All those things will be answered. Okay, let us try to make things concise and clear. Okay, let's try to make things clear. So let's begin with the first question. Basic question. Which of these is the most common type of pancreatic cancer? Which of these is the most common type of pancreatic cancer? Is it insulinoma, cystic neoplasm of pancreas, adenocarcinoma, or GIST, gastrointestinal stromal tumor? Yes, which is the most common type? These kind of questions, of course, we must get correct. We can't make a mistake in these kind of questions. They are very basic level questions. Okay, I can see your answers in the chat. Please reply in the chat box, guys. Okay, so the most common type, all of these can be seen in pancreas, just cannot be seen in pancreas. Just is gastrointestinal tumor. It's not a pancreatic tumor. The most common pancreatic neoplasm is adenocarcinoma. Okay, adenocarcinoma overall is the most common pancreatic neoplasm. You get cystic neoplasm, they are not so common, and insulinoma is a type of endocrine tumor. Alright, so simply put, when I look at the pancreas, it has a lot of different elements. Pancreas is nothing but a gland. Okay, it has a duct. It has the glandular elements, the acini. which open into the ducts. These ducts and these glands are your exocrine pancreas. They are your exocrine pancreas. Exocrine means what? They are going to produce digestive juices. Because their secretions will go directly through the duct into the duodenum. This is going to be your digestive juices: pancreatic amylase, pancreatic lipase, trypsin, chymotrypsin. Those are your exocrine pancreas. Also, the pancreas, remember, has those islet cells, islets of Langerhans, alpha, beta. Those are your endocrine cells. You know, insulin, glucagon, all those hormones are produced. Those secretions go directly into your bloodstream. So the two main tumors of pancreas are exocrine and endocrine. And there is a third group called cystic neoplasms. Okay, cystic neoplasms. Cystic neoplasms, we need to know only three names. First one is serous cystic neoplasm. Second is mucinous cystic neoplasm. So there is a serous type, there is a mucinous type, and there is a intraductal type. Intraductal. Okay, which directly open into the pancreatic ducts. They are called IPMNs. Intraductal papillary mucinous neoplasms, or IPMNs. These are the three common types of cystic neoplasms. Then you have exocrine. Exocrine means the proper gland, that is your adenocarcinoma. Adenocarcinoma, like you get in the GI tract, this is the most common one, 85%. Then you have endocrine tumors, insulinoma, glucagonoma, gastrinoma, all of those. Insulinoma, gastrinoma. I hope you have heard some of these terminologies: insulinoma, gastrinoma, glucagonoma. Okay, these are your main pancreatic tumors. तीनों का treatment is different. All three present differently. So we need to know a little bit about the common ones. How they present, what are the features, how are you going to treat them, how are you going to investigate them. Let's move on. Let's start with the most common one, that is adenocarcinoma. Let's start with the risk factors. All of these are linked with adenocarcinoma of pancreas. This is a pathology question more than anything else. Yes, all of these are associated with adenocarcinoma of pancreas. So now we are talking about exocrine tumor of pancreas. Exocrine tumors, except Peutz syndrome, HNPCC. You have heard of HNPCC, hereditary non-polyposis colonic cancer, chronic pancreatitis, or previous ERCP. Which of these is not linked with adenocarcinoma of pancreas? Yes, Peutz. I hope you have heard of both of these. They are both associated with colonic polyps, colonic polyposis. But mind you, these syndromes may be linked with pancreatic cancers also. Are they really linked? Chronic pancreatitis, is it linked with adenocarcinoma and previous ERCP? Okay, alright. So the answer is previous ERCP. ERCP has no connection with pancreatic cancer. ERCP is linked with acute pancreatitis. Okay, it is linked with acute pancreatitis, not with pancreatic tumors. All of these are linked with pancreatic tumors, especially I'm talking about adenocarcinoma of pancreas. So Peutz, I hope you have heard of Peutz. In Peutz, you get classically hamartomas in the intestine. You get hamartomas. You get lip pigmentation. And you may get adenocarcinoma of pancreas. HNPCC, it's not really linked with pancreatic tumors. It may be linked with duodenal adenomas, villus adenomas. It is linked more with periampullary carcinoma. Chronic pancreatitis, of course, is linked with adenocarcinoma of pancreas. Previous ERCP is not. What risk factor has the maximum risk? So what precursor lesion carries the maximum risk of CA pancreas? Yes, anybody? Which precursor lesion? And I'll give you a clue, it's not one of these. It's something else. It's not in one of these. Which precursor lesion carries the maximum risk of carcinoma pancreas? Yes? The answer is hereditary pancreatitis. Hereditary pancreatitis. Hereditary pancreatitis is a cause of chronic pancreatitis. It has the maximum injury to the pancreas and thereby the maximum risk of adenocarcinoma. Alright, so first things first, adenocarcinoma is the most common, 85%. Then they will ask you which is the most common site. Most common site is going to be the head of the pancreas, or loosely put, periampullary region. Periampullary region consists of four areas: the head of pancreas, distal part of CBD, so head आ गया उसमें, distal CBD आ गई, ampulla of Vater आ गया, where the pancreatic duct and the CBD open together, ampulla, and the fourth is second part of duodenum. These together comprise of the periampullary region. The question that I asked you was based on this principle: what are the risk factors? Important risk factor, smoking, but we need to know precursor lesions, so chronic pancreatitis and hereditary pancreatitis. Now what Bailey and Love says, hereditary pancreatitis increases the risk 40 to 50 times. The risk increases 40 to 50 times, the risk of adenocarcinoma of pancreas. And then the mutations. All the colonic polyposis syndromes increase the risk. KRAS mutation, which is also linked with colonic cancers or colorectal cancers. But KRAS is linked with sporadic. It's not linked with familial. It's linked with sporadic colorectal cancers. उसमें भी risk बढ़ जाती है. So all of these are risk factors of adenocarcinoma of pancreas, which overall is the most common type of pancreatic tumor. Let's move on. Coming to clinical features. So if the person has a malignancy in the head of the pancreas, all of these are going to be seen except. Yes, all of these are going to be seen except pruritus, clay colored stools, dark colored urine, or lemon yellow icterus. Which of these is not going to be seen in malignancy of head of the pancreas? Pruritus, clay colored stools, palpable liver, or lemon yellow icterus? Yes, any idea? Anybody? Do we see pruritus in malignancy of head of pancreas? If yes, then why? Or clay colored stools? What links? Or lemon yellow icterus? Uh-huh. Okay. Yes, anybody? Alright. So malignancy of head of pancreas can lead to obstructive jaundice. Okay, obstructive jaundice. So this is my head of pancreas. Like this will come my CBD, common bile duct, which opens into the ampulla. If there is a tumor in the head of the pancreas, it can obstruct the CBD, and that will lead to obstructive jaundice. This everybody knows. Obstructive jaundice will present with what? It will present with jaundice, clay colored stools, dark colored urine, and pruritus. So two things to you got clearly. Clay colored stool should be there. Pruritus should be there. Jaundice also ideally should be there. But mind you, this jaundice is not lemon yellow. This jaundice is deep yellow. It is deep yellow. Lemon yellow icterus is seen in which type of jaundice? Yes, anybody? कौन से टाइप ऑफ जॉन्डिस में आई विल सी लेमन येलो icterus, not deep yellow, lemon yellow. So lemon yellow icterus is usually going to be seen in hemolytic jaundice. Okay, it's going to usually be seen in hemolytic jaundice. So jaundice is of three types: pre-hepatic, hepatic, post-hepatic. Pre-hepatic or hemolytic में you will get lemon yellow icterus. Obstructive jaundice is post-hepatic. So the jaundice in post-hepatic causes is very very deep. It's not going to be lemon yellow. Palpable liver may be seen because of biliary dilation. Because of biliary dilation. So biliary dilation may lead to palpable liver. All of these points, mind you, are given in Billion Love. Palpable liver, and of course there can be a palpable gallbladder. That is called Courvoisier's law, which we need to know. Clearly what we need to know. Courvoisier's law. So what is Courvoisier's law? The law states if someone has obstructive jaundice and if the gallbladder is palpable. So obstructive jaundice with palpable gallbladder. Yes, good evening Anamika. Then it is not due to CBD stone. Okay, then it is not due to CBD stone. Why is it not due to CBD stone? Because this person should be having a shrunken and a fibrotic gallbladder. The gallbladder would be shrunken and fibrotic. That is Courvoisier's law. Courvoisier's law originally was described for periampullary carcinoma. So when Courvoisier described the law, he said periampullary carcinoma is obstructive jaundice and he will have gallbladder which will be palpable, and it's not gallstone disease or CBD stone. एक ही बात है. This was the original intent for which the Courvoisier's law was devised. Then they said no, this law does not really hold good. So anybody, what is the exception to Courvoisier's law? What are the exceptions? Yes, good evening Achan Khan. What are the exceptions to Courvoisier's law? This they ask in the exam very commonly. When will Courvoisier's law not hold good? There are two main reasons. The first reason is if the gallbladder is not fibrotic, not shrunken. Obviously, if it's not shrunken, it will be palpable. This can happen if the person has a early CBD stone. Means before the person got the cholecystitis and things, uske pehle he got a slip CBD stone and he got obstructive jaundice. Second reason is if the person has any supracystic blocks. Supracystic blocks. Supracystic means if the block is not in the CBD, if the block is in the common hepatic ducts. So if this is my liver and this is my gallbladder, this is my CBD, any block which is above the insertion of cystic duct, all of these are going to be exceptions. Because here the gallbladder will not be palpable and it will not be because of gallstone disease either. So these become exceptions. Early CBD stone and supracystic blocks. Alright, let's move on. This is an important question, perhaps one of the most important questions of the day. In a patient with malignant obstructive jaundice. Malignant obstructive jaundice means where the cause is a malignancy, like a periampullary tumor. That's what malignant obstructive jaundice implies usually. All of these are indications of preoperative ERCP, except. So if someone has a malignant obstructive jaundice or a periampullary tumor with obstructive jaundice, now you know what is periampullary carcinoma. You will do an ERCP in all of these indications except if there is a doubtful diagnosis, if he has periportal lymphadenopathy, if he has fever with rigors and jaundice, or if he has distressing pruritus. You know he will get pruritus. I just told you. So in which of these would you not be obliged, compelled to do a pre-operative ERCP? Yeah. In which of these am I not compelled to do a pre-operative ERCP? Doubtful diagnosis, periportal lymphadenopathy, fever with rigors, distressing pruritus. Yes. Anamika, Achan. If the diagnosis is doubtful, do I need to do ERCP? Okay. Anamika says distressing pruritus. Okay. If the diagnosis is doubtful, do I need to do ERCP? Yes, I can do ERCP with brush biopsy. I may get a malignancy. Of course, I can do. If he has fever with rigors, what does it mean? What is he having? If he has fever with rigors, इसका मतलब क्या होगा? He has jaundice and he has fever with rigors. Maybe he has pain also. What does that mean? What is he having? It means he is having cholangitis. In patient with cholangitis, I must do ERCP because I need to relieve the obstruction. Otherwise, cholangitis can progress to sepsis and patient can die. Raynaud's pentad लफड़ा हो जाएगा. He can end up in Raynaud's pentad. तो इन दो सिनारियों में तो मैं करूंगा. Distressing pruritus with long waiting period. Yes, if he's having too much pruritus, mind you, this pruritus does not go away automatically or with antihistaminics. It does not go away. It's distressing. And patient is not fit for surgery yet. It will take you some time to operate, maybe a week, 10 days. You can do a pre-op RCP. Basically, just to reduce the jaundice will reduce, and once the jaundice will reduce, the pruritus will reduce. Periportal lymphadenopathy has no connection with ERCP. This is the answer. Whether he has periportal lymphadenopathy or not doesn't make a difference to ERCP. It will not have a bearing on your ERCP. So remember, important features. Obstructive jaundice means he'll have jaundice, which will be a deep jaundice. It's not going to be lemon yellow. He'll have distressing pruritus. Okay, he'll have clay stools and he'll have dark urine. The tumor marker which is usually associated with pancreatic and distal cholangiocarcinomas is CA19. Okay, but it is not specific to CA pancreas. Mind you, it can be increased even if the person has cholangitis. So it's not specific to pancreatic tumors or cholangiocarcinomas. If the person has a periampullary tumor, I can of course diagnose him with EUS, endo ultrasound with FNAC. But if the MCQ comes, which is the preferred initial investigation, your answer will be CT scan. Because CT scan, it will not show you the tumor, but it will show you a clinical sign, not a clinical sign, a CT sign called double duct sign. What is this double duct sign? Anybody? What is this double duct sign? Any idea? That is seen in people with CA head of pancreas or periampullary tumor. Yeah, what is this double duct sign? Anyone has heard of it? It's a very nice finding that you can get. Now, if the person has a periampullary tumor, okay, which is causing obstructive jaundice, it's likely that it's not only blocking the CBD, it's also blocking the pancreatic duct. So what happens? The CBD dilates and the PD also dilates a bit. On CT scan, these ducts can be seen next to each other like this. Dilated PD, dilated CBD next to each other. This is called double duct sign. It is a feature of periampullary tumors. On CT, I will not see the tumor. Normally, I won't. They are very small tumors to be seen on CT. They are not very clear. They are not very enhancing. But yes, if I see both the dilated ducts, I can safely say this is a periampullary tumor. If I want to confirm, I'll do EUS with FNAC. Confirmatory test. Now, Let's say I am diagnosed an adenocarcinoma of pancreas. What treatment do I do? What decides the treatment? First things first, it should be operable. Operable means no metastasis, no local invasion. The tumor should not be invading important arteries or veins in the vicinity. It should be free from surrounding structures. Then it is going to be counted as operable. If it is operable, what are my treatment options? That we will see in the next question. Okay. Which of these is not always resected when I do Whipples procedure? Because one of the treatment options of adenocarcinoma of pancreas is Whipples. So which of these is not going to be always removed in Whipples procedure? We need to know a little bit about Whipples procedure. थोड़ा बहुत आना चाहिए. Yes. Is it gallbladder? Do I always remove the gallbladder? Or uncinate process? Or jejunum? Or common hepatic duct? Yeah. Which of these is not always removed? Do I remove the gallbladder, uncinate process, jejunum, or common hepatic duct? Which of these can be kept behind? Okay. So let us understand first what is Whipples procedure. Basic important points. Based on that, we are going to build the answer. Whipples procedure is usually going to be done for a periampullary tumor. Okay, this is the C of the duodenum. This is going to be the distal stomach, like this. This is going to be the jejunum. Now let's say the tumor is in the head of the pancreas. For example, यहाँ पर मेरी tumor है. Now when I am going to do a Whipples procedure, in one word, Whipples procedure is also called pancreatico-duodenectomy, PD, or pancreatico-duodenectomy. इसमें मैं क्या करता हूँ? First things first, I remove the head of the pancreas, neck of the pancreas, as well as the entire duodenum. So all this is going to be removed. Additionally, so if I have removed the neck, I am also going to remove the uncinate process. So uncinate process has to be removed in Whipples. This is the basic resection. But when I have to rejoin everything in place, I cannot join this jejunum. Okay, because this jejunum is at the DJ flexure. It is going to be stuck. I need some mobile jejunum, some free jejunum, because I have to join it to the stomach. So I resect some proximal jejunum also. How much do I resect? Till I reach free jejunum. So what have I resected? Importantly, I have resected head, neck plus uncinate process, entire duodenum, proximal jejunum. ये सब तो मैं निकालूंगा ही for sure. Additionally, यहाँ से मेरी CVD आती है. So my CVD is over here, gallbladder is over here, then CHD. I will always remove the gallbladder with some amount of CBD. Whatever is near the tumor, that also has to be removed along with the gallbladder. So, coming back to the question, not always resected, gallbladder will always be resected. Uncinate process will always be resected. Proximal jejunum will always be resected. CHD need not be resected. Okay, I just have to remove distal CVD, the part which is near the periampullary tumor. CHD निकालने की कोई जरूरत नहीं. So if the tumor is in the head of the pancreas, I am going to do Whipples. That is my first treatment option. If the tumor is in the body of pancreas or tail of pancreas, then I don't have to do Whipples. So for tumor in these areas, I do some other surgery. Then I don't have to do this complicated procedure. I can do something simpler. Yes, anybody? For tumor in the body and tail, what surgery do I do? So if the tumor is in the head, or neck? I'm going to do Whipples. Whipples, scientific term, pancreaticoduodenectomy. Tumor in body or tail. What am I going to do? I am not going to remove the head, I'll keep that intact. I will remove body and tail of the pancreas. May also have to remove the spleen because the blood supply can get compromised, or for oncosurgical resection. So for tumor of body and tail of pancreas, what I would normally do is a distal pancreatectomy. Distal pancreatectomy. These are the two main surgeries, main procedures that I do if the carcinoma is operable. If it's inoperable, then to khalas, then I can't do surgery, end of the story. If it's operable, depending on the location, head and neck, Whipples, body and tail, distal pancreatectomy, with or without synectomy. Normally I have to remove spleen, but I'll put over here with or without synectomy, depending on the oncosurgical margin I seek. ये MCQ बहुत बार पूछा है. Most common complication of Whipples is delayed gastric emptying. It is sort of like paralytic ileus, sort of. It's more like a gastric ileus, paralytic ileus of the stomach, जिसको बोलते हैं delayed gastric emptying. ये बहुत बार पूछा है. The most dreaded complication, if they ask you, the most dreaded complication, the most difficult to treat, is pancreatic leak. Because when I do Whipples, I do pancreaticojejunostomy, PJ. Remember, I resected all of these things in Whipples. So once everything is resected, I will be left with these small parts. I will be left with distal jejunum, proximal jejunum निकाल दिया. I will be left with a little bit of CHD. ये सब मैंने निकाल दिया है. I am just showing you what all is left. यहाँ पर jejunum रह जाएगा. Okay, so what I have to do? This jejunum has to be joined to the stomach like this. It has to be joined to the CHD, and it has to be joined to the pancreas. So there are three anastomosis that I do. I do gastrojejunostomy, hepaticojejunostomy means CHD to jejunum, and pancreaticojejunostomy, so that all the secretions get drained into the jejunum. This is the most important anastomosis because this is the one, if it leaks, it's going to be a mess. Okay, any doubt with Whipples? Are we good with Whipples? Important points, plenty of MCQs, plenty of theoretical aspects, but let's try to keep it simple. ये सब अपने को आना चाहिए. Let's move on. This question was asked, easy question in NEET 2020. Most common neuroendocrine tumor of pancreas: gastronoma, insulinoma, VIPoma or somatostatinoma. All of them are seen in pancreas. ये सारे के सारे pancreatic endocrine tumors हैं. Which of these is the most common one? Yes, gastronoma, insulinoma, VIPoma or somatostatinoma. NEET में पूछा था. It was one of the easiest questions they could have asked in NEET PG. NEET PG का surgery questions were not so easy. These were some easy ones which you had to get correct in the first go. So overall, most common endocrine tumor is insulinoma. This is overall. If the question was most common endocrine tumor of pancreas in men syndrome, multiple endocrine neoplasia, then what will be your answer? If the question was most common endocrine tumor of pancreas in men syndrome, then what will be your answer? Then the answer becomes gastronoma. Okay, so in men syndrome, it is gastronoma. Overall, it is insulinoma. Mind you, men syndrome is a very small population. Not many people have men syndrome. But if someone has it, they know they have it because this is autosomal dominant. It runs in families. तो अगर किसी को मेन सिंड्रोम है, they know their father had it, he had a pancreatic tumor, he had hyperparathyroidism, पता रहता है. So you do genetic testing in these people. They will also have a gastronoma. But overall, insulinoma is far more common than gastronoma, as you can see. Overall, most common insulinoma, in men syndrome, gastronoma. Then there are some others, glucagonoma, VIPoma. They love asking questions on these endocrine tumors, so I will put some questions on these. Okay, this is another important question of the day. There is a female recently diagnosed diabetic, so she has diabetes, female. She has this rash. She is also suffering from depression. So diabetes, rash, depression, what is going wrong? It's a very unusual combination of things. What blood investigation from all of these will you advise? Chromogranin A, gastrin, insulin or glucagon? And you need to identify a little bit about what this rash is, because it's a very classical rash. Yeah, any idea what this rash is? What does it signify? Yeah, great. So this is what is called as necrolytic migratory erythema. Necrolytic migratory erythema. Okay, this rash, so rash or dermatitis, diabetes, depression becomes glucagonoma. Glucagonoma. So to diagnose this, you are going to ask her to do fasting glucagon. What is glucagonoma? We don't need to know too much details. We just need to know the important points of some of the pancreatic tumors. Glucagonoma. Just remember, it is the rule of the D's. There are 4 D's in glucagonoma. Diabetes, dermatitis, depression and DVT. Mind you, there is DVT. Okay. And in your exam, they will change one of these options and they'll put an option of diarrhea. Okay, because they know you know the 4 Ds. They'll put diarrhea. Remember, diarrhea is not seen in glucagonoma. Diarrhea is seen in the other endocrine tumors, but not in glucagonoma. Very clearly, I'm telling you. यही डालेंगे because सबको पता है 4 Ds of glucagonoma. But there is a DVT, there is a depression, and there is no diarrhea. So in fact, you should call it 4 Ds plus 1 D, which is missing. Actually, there are 5 Ds. There is one tumor called VIPoma. Okay, VIPoma, vasoactive intestinal peptide, important enzyme. Vasoactive intestinal peptide. It's also called the universal switch on hormone, GI hormone. It causes watery diarrhea. So the secretions increase massively as if the person is having cholera. Like you know how in cholera we have rice water stools? वैसे इसमें होता है. Massive diarrhea, massive electrolyte imbalances, hypokalemia, achlorhydria. Okay, this is your VIPoma. Please remember, VIP is the most important hormone because it will switch on everything. It's called the switch on GI hormone. Okay, so these persons will have tremendous secretions like a cholera person. There are some endocrine tumors where there is no endocrine hormone produced as such. So they are non-functional. In them, you get synaptophysin or chromogranin. So this chromogranin or synaptophysin would have been for non-functional endocrine tumors or minimally functional endocrine tumors. Okay, are we good with this? Let's move on. This is a new question. I have just framed this, but easy question. आज तक पूछा नहीं है ये, इसलिए मैंने डाला है. Insulinoma, I told you this was the most common tumor, most common endocrine tumor of pancreas. What is the preferred surgical treatment? So normally I try medical management. But if the person is very symptomatic, what should I do? Should I surgically enucleate it, do a wide excision, do a lymphadenectomy with enucleation, or do a wide local excision and lymphadenectomy? ये न्यू सवाल है, ये आपको एमसीक्यू बुक्स में नहीं मिलेगा, पर ये बेलियन लॉ में दिया है. Preferred surgical treatment of insulinoma. Yes, सॉरी, इंपॉर्टेंट सवाल है और बहुत टाइम से उन्होंने इस पे कुछ पूछा नहीं है, which is why we need to be a little wary of this kind of a question. ऐसे टाइप के क्वेश्चंस आ सकते हैं. So insulinoma most of the times is benign, which means lymphadenectomy वाले दोनों option out. So you have to think enucleate or wide excision. Answer is going to be enucleation. Okay, enucleation means just remove the tumor. Wide excision means remove with margin. Yes, enucleation is the answer, Anamika. Wide excision means remove with a normal margin, जो insulinoma में is usually not required. So insulinoma, what are all things we need to know? What are the important points that we need to know? First things first, Whipples triad. Okay, remember there was a Whipples procedure. This is Whipples triad. Whipples triad means insulinoma, high insulin production, person will have profound hypoglycemia. Profound hypoglycemia, typically after fasting. You check his sugar, it will be dangerously low. And you give him glucose, it will improve. Hallmark of insulinoma, Whipples triad. Remember, to diagnose insulinoma, you need either fasting insulin or fasting C-peptide. When insulin is produced, it is produced as a proinsulin. Okay, which breaks down into insulin and C-peptide. So when I measure C-peptide, I am sort of measuring insulin only. Sort of. It's a proxy of insulin. It's like a byproduct. Since this is usually benign, medical management usually controls it. So this is going to be anti-insulin hormone effect, diazoxide. Otherwise, I do surgical excision. Enucleation will take care of the insulinoma forever. Okay, let's move on. This again is a very important question. Conceptual question. You know on what ground this question is based. There is a 35-year-old male. He has a long history of epigastric pain. It's not really improving after PPI. He undergoes an endoscopy and there are multiple ulcers seen in lower esophagus, in the body of the stomach, in the antrum of the stomach and in duodenum. Means everywhere he's having ulcers. Epigastric pain. Not really improving with PPI. What is he having? What is this weird conundrum of symptoms and ulcers everywhere in the body? Yes, and then you have to first identify the pathology and then think about what is incorrect. So first you have to identify the pathology. The pathology is Zollinger-Ellison syndrome. Yes, Zollinger-Ellison syndrome, which is seen in someone with a pancreatic tumor called gastronoma. Remember, gastronoma, most common tumor in men syndrome. So if someone has a men syndrome, usko gastronoma hoga most of the times. So the question is asking you, identify the incorrect statement about gastronoma. That is what the question is asking you. Gastronoma के बारे में क्या गलत है? Fasting gastrin is diagnostic, absolutely correct. Diarrhea is seen, absolutely correct. I told you, diarrhea is not seen in glucagonoma. दूसरे endocrine tumors में होता है, like BIPoma and gastronoma. Both of them have diarrhea. Gastronoma, SRS is diagnostic. Yes, it is diagnostic. 24-hour pH study is gold standard. Is this correct about gastronoma? Absolutely not. 24-hour pH study is gold standard for GERD. Please remember. 24-hour pH study is diagnostic or gold standard for GERD, gastroesophageal reflux disease, not for gastronoma. Okay, gastronoma I've already seen. If I want to identify it, either I'll do SRS or I can do CT pancreas or MRI pancreas, something like that. It is always going to be seen in that triangle of Passaro. It is always going to be seen in that triangle of Passaro. If they ask you most common site, you will say duodenum. ये भी NEET में पूछा था. This was also asked in NEET 2020. Most common site. So we always think of triangle of Passaro. उसमें the answer is duodenum. These are usually malignant. So here the treatment is going to be lymph node excision. Enucleation is fine. I don't need a big margin. But I have to remove lymph nodes because lymph node metastasis is common in gastronoma, which is not seen in insulinoma. That's where the answers are different. So either they will ask you treatment of gastronoma or they will ask you treatment of insulinoma. दोनों में enucleation but insulinoma is benign, so no lymph node excision. Gastronoma is malignant, so lymph node excision is advisable. Okay, and this point 100% positivity for somatostatin receptor scintigraphy. Okay, 100% positivity for somatostatin receptor scintigraphy. All right, let's move on. This is a new question. It's based on a recent concept called borderline resectable pancreatic cancers. So in earlier days, if someone had a pancreatic tumor, now understand pancreas has a lot of major vessels in its vicinity. Behind the head and neck of pancreas, you have the portal vein. You know portal vein. Portal vein formed by superior mesenteric vein. This is your portal vein. This is my splenic vein. This is my superior mesenteric vein. So there is portal vein. Then there is superior mesenteric artery. They all run together. ऐसे जाती है superior mesenteric artery. उसके पीछे से. Splenic artery runs on the pancreas. Gastroduodenal artery that also runs somewhere over here in the vicinity of the pancreas. So which of these, even if there is a tumor, it is involving any of these, is not considered as borderline resectable? Means cannot do surgical resection. Is if there is involvement of which of these? Portal vein invasion, SMV invasion, SMA invasion और GD encasement. ये new है, ये important है, ये बेली में है और ये आज तक पूछा नहीं है. थोड़ा high level है, but these kind of questions are directly from the book, so you can't say this is out of syllabus or very high level. So if the tumor is just involving the portal vein, I can still do resection. Remember, in liver tumors, portal vein invasion was a contraindication. So if it was liver tumor and there was portal vein invasion, it's contraindication. Pancreatic tumors, portal vein abutment, not a contraindication. SMV abutment, not a contraindication. GDA, not a contraindication. Answer is SMA invasion. ये पूछा नहीं है आज तक. ये question आना ही चाहिए. If the SMA, superior mesenteric artery, is involved by the tumor more than 180 degrees, then it becomes unresectable pancreatic cancer. Okay, then it becomes unresectable. तो ये पॉइंटें हैं, ये याद रखनी है. SMA, SMV or portal vein venous involvement is okay. I may be able to do a excision of the vein. GDA encasement, and this is the one where they'll frame the question. Up to 180 degrees SMA is okay, and that also only abutment. Abutment means this is the tumor like this and this is the SMA. It should only be abutting. It should not go inside. That is okay. 180 degrees. Like if it's more than 180 degrees, then the tumor is going to be hard to excise. I cannot excise the SMA. SMA supplies the entire gut, almost entire midgut. So all your small bowel is based on SMA. If SMA has to go, सर एक बार फिर एक्सप्लेन कर दीजिए, विच पार्ट डू यू वांट फिर से एक्सप्लेन? इफ द ट्यूमर इज इन्वॉल्विंग SMA up to 180 degrees, so this is my superior mesenteric artery like this, and if the tumor is only up to 180 degrees involving, not more than that, मतलब इतना ऐसा ट्यूमर आ रहा है, then it's okay. But if the tumor goes more, then it's going to be a problem. The tumor should not invade the artery, because understand, SMA cannot be sacrificed. Okay, it cannot be sacrificed. SMA supplies the entire small bowel and part of colon also. If anything happens to SMA, it becomes inoperable or unresectable. Okay, so feature of unresectability is SMA involvement more than 180 degrees. Okay, let's move on. Which of these pancreatic tumors? So now we are doing the last part, that is cystic neoplasms. So we did adenocarcinoma, we did endocrine tumors. Now we are doing the last part, that is cystic neoplasms. इस पे काफी टाइम से क्वेश्चन आया नहीं है, so this is something again we need to be careful of. Which of these pancreatic cystic neoplasms is seen exclusively in women? It's never seen in men. Serous, mucinous, main duct, IPMN. I told you what is IPMN, or branch duct, IPMN. Which of these is seen exclusively in women? Serous cystic, mucinous, main duct, or branch duct? Answer is mucinous cystic. Mucinous cystic neoplasms of pancreas are associated, or they show what is called as struma ovary. Struma ovary. Which means if I do a biopsy of this tumor, it shows stroma which looks like ovarian stroma, which obviously cannot be seen in a male. So it is believed to be, maybe it's a metastasis from ovarian tumor, maybe, okay, or a hamartoma of some sort, but stroma ovary is the hallmark, and obviously stroma ovary cannot be seen in men. So this type of tumor is seen exclusively in women. It's never seen in men. Okay. So on similar lines, which of these tumors shows thick mucus when I do ERCP? So when I do ERCP, it's a typical appearance. I I open the pancreatic duct, and a mucus secretion starts coming in the ampulla. It will be seen in which of these tumors? Serous cystic, mucinous cystic, main duct, or branch duct? IPMN. Yes, serous cystic, mucinous cystic, main duct, or branch duct, IPMN. So first things first, if something is coming into the ampulla, okay, means pancreatic duct जहाँ open हो रही है ampulla में. If something is coming into the ampulla, means it is coming from the pancreatic duct. It can't be a serous or a mucinous cystic neoplasm. It has to be something from the pancreatic duct. ये दोनों में तो possible नहीं है. Answer is main duct IPMN. IPMN, if you want to think simply if you want to see, IPMN, intraductal, means the papilla has to be inside the duct of the pancreas. Obviously, if it's inside the duct of the pancreas, whatever are the secretions will come out from the ampulla. Hence, the answer is main duct. Branch duct may be हो सकता है, but the chances are less. Possibility is very less. So, about cystic neoplasms of pancreas, what are the important points? There are three types. First is the serous cystic, which is benign. Okay, and just remember this point. Why we need to know about cystic neoplasms of pancreas? Let's say there is a big cyst in the head and neck region of the pancreas. A lot of times I don't know, is it a true cyst like a cancer, or is it a pseudocyst? You know what is a pseudocyst? जो होता है in setting of pancreatitis. It's a complication of pancreatitis. A lot of times I don't know whether it's a true cyst or a pseudocyst. Pseudocyst is always seen when you get pancreatitis, क्योंकि दोनों का ट्रीटमेंट अलग है. ट्रू cyst है और benign है, I don't need to do anything. But yes, malignant true cyst has to be operated. Pseudocyst has a different treatment. So I need to know that this cyst that I see in the pancreas, is it true or is it pseudocyst? Right? How do I make out whether it's a true cyst or a pseudocyst? Remember, pseudocyst is always going to be amylase rich. True cyst of the serous type is going to be amylase poor. Fluid is low in amylase. Coming to the next one, mucinous cystic. Mucinous cystic, the important thing exclusively in females, and ovarian type stroma. Okay, ovarian type stroma. Now, because they can be malignant, they show a tumor marker. But again, amylase rich nahi honge because it's not in the setting of pancreatitis. Okay, because it's not in the setting of pancreatitis. The third type are your intraductal papillary mucinous neoplasms. They are usually malignant. They can be main duct type or branch duct type. They will show both high CEA because they are malignant, and because they are in the duct, they will be rich in amylase. And they have to be resected. They have to be resected. So these are the three important cystic neoplasms of pancreas that we need to know. So baat ki ek baat, there are 4 diseases which look like pancreatic cysts. One is a pseudocyst, which happens in the setting of pancreatitis. Then you have serous cystic neoplasm, then you have mucinous cystic neoplasm, and then you have IPM. All 4 of them look like cysts of the pancreas. How do we differentiate? We will differentiate based on if the cyst is having high level of amylase, is it amylase rich, or high level of CEA. If you aspirate the cyst and you check for these things, you will be able to differentiate all the 4. Pseudocyst, it will be amylase rich, but because it's a pseudocyst, it's not a tumor, CEA will be absent. Serous cystic neoplasm, it is a true cyst of the pancreas, it's not in the duct, no amylase, no CEA. Mucinous cystic neoplasm, again usually it's benign, it's not in the duct, but CEA may be elevated. IPMN, both will be elevated. Simple test, just by aspirating, you can differentiate the 4. Okay, this perhaps is the most important slide of today. That's why I've written it down. This is what you need to grasp from these 4 cysts, true cysts and pseudocysts to diagnose. Treatment is easy. To treat pseudocysts, you treat the pancreatitis. If required, you do drainage. SCN, surveillance. Mucinous, if they are large, then resect. Only if large, then you will resect. And IPMN, always resect because they are always malignant. Simple. Life can become easy if you have a little structure to how you study and how you prepare. Alright, so we'll end the class here. Hope you guys enjoyed the class. A lot of important concepts of pancreatic tumors were cleared. Try to study this once. Make notes from this class. It will become a lot easier to solve questions on these topics. Alright, do follow me on the Unacademy Educator app. I will be taking a lot of free live classes, special classes, and a lot of YouTube videos in the upcoming days and weeks. And if you have any doubts, you can message me on Telegram. This is our channel, Unacademy NEET PG. You can follow me over there and you can send me a message. If you wish to learn more from me on the Plus platform, please use my referral code, that is 10 surgery. Where on the Plus platform, I will cover everything in surgery comprehensively. Okay, so hope you guys enjoyed this class. Do join me for my upcoming classes. Take care, study well, and